الحقيقه انا نفسي مستمتع بالدسكشن اللي كان عشان كده ونفسي نكمل بصراحه. يعني هي برزنتيشنز هايله لغايه دلوقتي. First of all, I would like to thank the coordinators of this meeting for giving me this opportunity to present this presentation, and another special thank for giving me this topic, because I like talking about this topic in giving spectacles in children, because it's something we see in everyday practice, and all of you are prescribing glasses for children. So let's talk about an idea about giving glasses in children in strabismus patients. When we talk about glasses in strabismus patient or even prescribing glasses in children, we are dealing with something with a high controversy. There's really a high controversy between consultants on when to prescribe glasses, what's the amount that you start prescribing glasses for. Starting history, as usual, the ancient Egyptians were the first to create everything. The magnification has been written as a simple glass meniscus lens has been mentioned in 5th century BC. But the first to prescribe convex lens and mentioning that we have a convex lens is Al-Hasan al-Haytham in his book of optics or Kitab al-Manazir in 1000 AD. But the early recorded evidence for glasses was an entry in 1286. So today's lecture will speak about how to check for refractive error and when to prescribe glasses, including factors influencing the decision, and glasses in some special situations like strabismus, and a hint about prisms in the glasses. So how to check refractive error? When to do cycloplegic refraction, and to which age, and how to do this cycloplegic refraction? Would you use manual or automated autorefractometer? And when to do trial and how? When to do cycloplegic refraction in children? Simply the cases of strabismus, every case of strabismus should do cycloplegic refraction. And even we may think in repeating cycloplegic refraction in special situations, like patient with amblyopia is not improving, we can re-refract the patient. If we have residual angle with glasses and we are going for surgery, and can be repeated every year or every 2 years according to the case. Patient going for strabismus surgery, we usually recommend double checking the refraction. Maybe there's still some extra class I can give for just, for example, case of partial accommodative esotropia. And even with children without strabismus, if I am suspecting refractive error in children, we go for cycloplegic refraction, at least one in the records of the patient. Patient with high variable dynamic refraction or patient with accommodative spasm, even if a teenager, I need to do the cycloplegic refraction. If I have a patient with family history of refractive error, it's recommended to do cycloplegic refraction for them. Even if patient without a sign, without any symptom, it's recommended to have a cycloplegic refraction at least as school entry, hopefully even before. So what are the agents we use for cycloplegic refraction? This is a picture from the academy, but this table from Kenneth Wright's book is more detailed, talking about the cycloplegic effect and the mydriatic effect. So we have to differentiate between the drugs. There is a mydriatic effect and there is a cycloplegic effect. What we are talking about here is the cycloplegic effect, not the mydriatic one. So like tropicamide or medracid, here we can see that the maximum effect is after 30 minutes of installation. So this is very important. If you're going to use a medracid, you have to check in this period, not more than this. Cyclopentolate, we have a wider range, 25 to 75 minutes, so we have a wider range. So it's more practical in the clinic with the patient waiting outside. It's very hard to get the patient inside in an exact time, so it's very practical in this. It can be up to 75 minutes. And its effect lasts for only maximum 24 hours. So the effect of cyclopentolate, maximum 24 hours. So for atropine, as you may know, the cycloplegic effect can stay up to 12 days, but the peak is within 60 to 180 hours. So the message here that prescribing mydriatic for 3 days for atropine is recorded as an accumulative effect, but for cyclopentolate has no rule. Giving prescribing for kids cyclopentolate for 3 days, there is no rule for this because its maximum effect is is in 25 to 75 minutes, but it lasts after 24 hours. You can use a cycloplegic refraction combinations, like combining drops. In vascular pharma, they were using this combo drops, cyclopentrate plus tropicamide plus phenylephrine in one drop. You may precede a topical anesthesia before applying the mediatic drop. It has this stinging sensation and may even enhance ocular penetration of the drops. There have been a lot of studies. Don't bother yourself reading with this. A lot of studies comparing cyclo versus midazolam, atropine versus cyclo, and so on. A lot of studies in this. So I would like to summarize most of the studies. That most of the comparative studies showed that atropine refraction showed more hyperopic refraction, but not too much. It's like about 1 diopter. Specifically, in patients with diet eyelids, patients with esotropia, and younger children. Yet, some studies showed that this difference is statistically insignificant. And in myopia, most of the study, the difference is insignificant. So, to conclude, the recommendation for cycloplegics, when to do cycloplegic refraction, or what to use, midazolam, cyclopentolate, atropine. So I believe in children in general, without strabismus, or even with exotropia, cyclopentolate can be a routine, avoiding using the atropine with its known side effects. But with children with esotropia, if you want to add atropine, it's fine. But for school age, again, I prefer cyclopentolate for avoiding blurring a child in a school for 2 weeks. If you want to give atropine, please, you can use it in residual esotropia going for surgery. I want to double check. It's fine, but please counsel the patient first for the possible side effects. Refraction. We'll use auto refraction or manual refraction. Auto refraction, definitely we are using it as a routine. However, manual refraction, double checking, I believe it's a must. Double checking the refraction manually. The retinoscopy is a talent that we should not lose. We should keep this talent. In some cases, we can only do manual refraction, like cases with any problem with the cornea, any myocarditis in the lens. Sometimes it's a must to have a manual refraction. This picture I'm showing that although we have the handheld auto refractometer, still I'm using the retinoscope as a double checking. Is it easy to approach a child? Sometimes this is the challenge, actually. Sometimes it's not easy to approach a child. Sometimes it's a mission impossible. Sometimes we face a situation like this. I cannot do refraction. It's a child, it's a crying child. I cannot do that. But believe me, spend few seconds to few minutes playing with kids. Most of kids, different nationalities, same things they like, same things they fear of. Few times you can get a happy child, you can get all whatever you want from this child. You can do refraction, you can do fundus examination, you can do what you want with this patient. So the message here, examination under anesthesia is not a routine. I don't think it's a good thing. This child is with strabismus, so I should put the patient under anesthesia to do refraction, to check the fundus. You can still get all the data that you want without putting the child in examination under anesthesia. It's an extreme exception. Spend some time playing with the child. Start with the less invasive procedures. Then the more invasive, like start with the manual refraction, you're staying quite a bit far from the child. Then the automated refraction, the portable refraction. Make the fundus examination at the end where you clear sunlight in his eyes, so make it at the end. So you can keep the cooperation till the end of the examination. Examination under sleeping. It's very nice, it's very helpful, especially in young children. Usually when they get drops, they cry, they get blurred image, they get bored, they go to sleep. So many mothers, when the child goes to sleep and have been called the child for the examination after the drops, they wake up the child, wake, it's time of examination, and the child came to you, bothered too much, he's very unhappy, he just came up after sleeping, so this is the worst situation for you. The best is the child is very awake that you can play with, or sleeping that you can take your time. So I instruct mothers that if the child wants to sleep, let him sleep, get him inside sleeping, then you can have time to do examination under anesthesia with the child just, not under anesthesia, just on sleeping. Of course, sedation, there's a rule for sedation, definitely. Some people are doing it as a routine. Okay, we don't use it in our hospital for safety measures, but it's fine. Of course, it's recorded, it's there. Then the question is, do these numbers appear in this refraction? Deserve glasses? Yes or no? So should I prescribe glasses if I have an infant, 1 year old, with 0.5 diopter? Should I give glasses? Should I don't give glasses? So the question raised, to prescribe or not to prescribe, that's the question. It should be, the answer I believe is, it should be individualized for each child. There is no hard line, there is no black and white measure when to give glasses. It should be individualized for each child. Many factors affect this, affect your decision to give glasses or not. For example, the age. I believe the age is one of the most important factors in giving a child a glasses. Of course, an infant, 1 month old, different than a child 10 years old. So the threshold of giving glasses, I mean, what's the number above which I should give glasses? Of course, it's higher in the threshold. Sorry, that I go in infants. I use higher numbers to give glasses. Small numbers I can omit. The presence of symptoms: patient complaining of atrophy, especially school age children, patient with athenopia, headache, ocular discomfort, and so on. I can give numbers, glasses, even in less numbers than what I usually do. Presence of signs like strabismus, recurrent style, whatever, I can even give glasses with less number than I used to. Patient with high ACR ratio, I have taken my focus. If you have a history of previous glasses, try not to decrease the hyperopia or increase the myopic glasses more than one diopter in one visit. The general health and developmental delay. Usually a patient with some developmental delay, I can omit small numbers and make my threshold higher than usual. When to do subjective refraction? At what age I should do subjective refraction? In a general accommodative child, I can use subjective refraction. Usually we talk about patients with above school age. But the result of subjective refraction should not be just prescribed as this. We should do something which is more important here than doing the cycloplegic refraction. So we have to do additional cycloplegic refraction, do the subjective but still do cycloplegic refraction, then compare the two results, try not to have a significant difference between the two measurements. And of course, if we have associated disease like strabismus here, of course, I will alter my numbers accordingly. Like patient with esotropia and hyperopia, I give higher numbers than usual. Duochrome test is very helpful in doing this subjective refraction in children, because they have quite a good accommodation. So it can help us and give us an idea if we have overcorrecting. So to summarize this, I think this slide can be nice to summarize things. I don't want you to get confused. So at the end, what's the number I should prescribe and what the number I should not? When I should do subjective refraction, when I should do cycloplegic refraction. So I think this slide can answer this question. In the first 6 years of life, it's been, usually we talk about preschool, we do cycloplegic refraction only. You don't have to do subjective refraction. It's hard to do subjective refraction. The next 6 years, which is from 6 to 12 years, we're talking about a school age child. So you can do trial, but plus you have to add cycloplegic refraction and before you give the final decision of the glasses. Above 12, trial is easy enough in most of the cases. However, some cases we may need to do cycloplegic refraction, as I mentioned before. The type of error and age. So again, what's the number? I should, above it, I should prescribe the glasses. This is from the American Academy, the guidelines for the American Academy. That, for example, patient with myopia, it is in the first age, 0 to 1, 1 to 2, 2 to 3. The recommendation for the American Academy is that for myopia, in the first year of life, I can ignore up to -5. And hyperope up to and in this next year, I can ignore up to -4, then up to -3. And for hyperopic patient without strabismus, without esotropia specifically, I can ignore up to 6. In the second year, up to 5. In the third year, up to 4.5. And for astigmatism, I can go up to 3 in the first year, up to 2.5, up to 2. This is concerning there's no other abnormality, there's no strabismus, there's nothing else in the case. Another table from Prescribe book. If we have an isometropia, things differ when we have other thing. That there's a threshold that above which the isometropia can be amyloidogenic. Like in hypermetropia, the difference can be as little as 1.5. Myopia difference with -3, and astigmatic 1.5. So as a general rule in an isometrope, for those who cannot see what's written down, an isometropia always exists. Isometropia, please respect the difference between both eyes, even if the difference is high. I mean, patient without strabismus, you're doing cycloplegic refraction, is +5 and +4. +5 in one eye, +4 in another eye. You want to subtract something before giving the glasses. Some people subtract like 1 diopter, maybe more, maybe less even. But whatever you are going to subtract, make it the same between the two eyes. It's +5, +4, and you want to subtract 1, make it 4 and 3. Not subtracting 1 and subtracting half in another eye, in the other eye. So keep the balance between the two eyes, even if you have high numbers. Because most of the cases, unless doing surgery like a phakic patient, most of our cases are axial ametropia, axial myopia, or axial hyperopia. So these cases are not associated with anesioconia usually. So you can give this difference even if you have high number, even if you have high difference between the two eyes. Okay, so how to convince children to wear glasses? Simply convince the parents first. And the objection of parents is something like, my child specifically can't wear glasses. I know my child, how can the child can wear glasses? How on earth a 1-year-old boy can wear glasses? So convince the parents, counsel the parents first. Some recommended answer like, okay, I agree, it's difficult, but definitely it's not impossible to prescribe glasses, and giving the assurance that in the first few days the child will have some difficulty. After this, the child will like it. The child will have better vision, so you like it. In most of the cases, they will like it, and so on. Then you educate and advise the parents to be positive attitude. You may give some advices about the frame. Let the child choose the frame, so he may like it. Third, after all this, it came back, the child cannot wear the glasses. So you need to double check what you did. Simply double checking the power of the lens. So the lens, the glasses been done fine. Double check the refraction, it's okay to do so. And simply ask the child, what's the problem with the glasses? Many times the child is refusing the glasses because it's brown and he wants red glasses. So it's nothing to do with refraction. So just ask the child, what's the problem? So this coming slide is talking about, I have a given strabismus, I have a refractive error. The two common scenarios, esotropia with hyperopia, exotropia with myopia. So any child, hypermetropia and esotropia, the classic thing, in the first visit to give a full cycloplegic refraction. This is basic. Esotropia, hyperopia, but here I'm talking about the first visit, not always, not all for all life. For the first visit, we give full cycloplegic refraction. Next visit, like after 2 or 3 months, we are expecting one of these three scenarios. Patient coming orthotropic, patient coming with equal esotropia, or ortho for distance and esotropia for near. So if the child is ortho, it's fine, we can keep it. But in further visits, still orthotropic, I can gradually decrease this full cycloplegic refraction. If the child having residual esotropia, again, before jumping to surgery, I can re-refract the patient. I can overplus the patient. If you have amblyopia, definitely you should treat it, and the surgery is at last. If a patient with orthotropia for distance and esotropia for near, this we're talking about patient with conversion excess, then we can prescribe bifocals, or sometimes we can go directly for surgery like Fallon procedure. The bifocal has to be, the best is to be like this, executive bifocal, and have a horizontal line bisecting the pupil. It's very hard to be done perfectly, but it should be done perfectly. The other situation, myopia with exotropia. Again, in the first visit, we respect the minus, we give more than, usually we give more than cycloplegic refraction, we can even over minus from the first visit, then according to the situation afterward. If the patient orthotropic, I can gradually decrease this over minus. The same idea, residual exotropia, re-refract, over minus, amplifier treatment, final surgery. If we have ortho for distance, XT for near, we do convergent exercise, not surgery. The IPD measurement is important. Don't rely on the optician in this, especially in strabismus patients. How to do it? Just make the patient fixing with one eye, then cover and fix with the other eye, and take the IPD measurement. And amblyopia, Dr. Ayman are going to give us a full idea about the amblyopia, but just I want to mention something related to the glasses here, that in big amounts, especially in hyperopia, we give full cycloplegic refraction from the beginning, even if you don't have esotropia. I'll give you an example of this file. If we look here, this is the dry retinoscopy, it's +9. This is the full cycloplegic refraction, it's +9. Many times we face these patients like this. From the first visit, there is no esotropia. I'm talking about patients without esotropia, with high hyperopia. This patient having lost the accommodation, so this patient should be given full cycloplegic refraction to gain again the accommodation. On penalization, when I want to make penalization and put atropine in the good eye, I should give less plus in the fixing eye, it's a kind of penalization, and give a full plus in the amblyopic eye. For example, a patient with +3 in the right, +5 in the left. This is the amblyopic eye. I'm giving here atropine. I prescribe plano here. I give the full plus in the other eye. So it's a kind of making the child penalized. So for near, he needs even this +3 needs more +3. So that is really blurred, especially for near. So this can help in amblyopia treatment. Fold lenses, I don't recommend it like this. This patient, can you see, making glasses with this tint, so obstructing the vision. But many of these child can make these tricks and look up of the frame. The last thing I would like to talk about the prism. It's used in diploptic patients. We have 3 main ways of applying prism: the Fresnel prism, the grounding prism inside the same lens, and we can use the decentration. If you remember the Prentice rule, you can use it in few amounts needed in prism and in high refractive error. A Fresnel prism is a plastic, easily removable, changeable sheet. It's good for variable deviation, and it's helpful in high numbers. It can reach up to 45 prisms, so it's very good in high numbers. But the prismatic effect is a problem. Can give like a rainbow effect. This is a picture this morning after the sunset. This rainbow appearance can happen with prism. The ground in, we insert in the glasses. The problem is that it has a limitation. They don't give big numbers, maximally 6, 8. Sometimes some opticians doing more, but it's not a big numbers like the Fresnel prism. So this is a very short video on how to apply a Fresnel prism. This is a Fresnel prism. I want you to be aware of this. I know some of you didn't see it before. It's a plastic sheet here. In one corner, this is a plastic sheet, one smooth surface and one with prismatic surface. You can look at the corner and see what the written the power. Here you can see the lens. If you are to put the prism in front of a straight line, you can see the shift of the image. It's written where is the base, so you know where the view. Now you apply it on the glasses in the inner surface of the lens, making the concavity of the lens a way to fit the prism. Then you put mark on the size, exact size of the glasses, and then after this you cut the same size. So by cutting it, it fits in the inside portion of the glasses, as you see here. And then you put it, you get the glass. This patient with left 6 nerve, esotropia, so here base out, left base out. As you can see, the image is shifted. You may put water, as you can see here, a drop of water to avoid the air bubbles. And after this, you can dry it. You can dry it and leave it for complete dryness, as you see here. So it fits the glasses. So now you can see it, and you can see the image shifted. In single-eyed patients, just last reminder that this patient should wear a protective polycarbonate glasses most of the time to protect the good eye. Thank you very much.